The presenter of this program, this topic, is a professor and consultant in public health and community medicine at the University of Benin Teaching Hospital. He currently serves as the Director of Central for Artificial Intelligence Development at the University of Benin. His educational background is robust, featuring degrees and fellowship in medicine, public health, and bioethics from prestigious institutions. He served and held very many offices, to include Deputy Chairman of the Medical Advisory Committee on Research and Ethics at the University of Benin Teaching Hospital. In addition to his professional achievements, he has published, authored with nearly 50 academic publications, and has served as a consultant for various health organizations.
Thank you.
Ladies and gentlemen, let us, with a rousing ovation and a clap, welcome to the podium Professor Omokhoa Adeleye. Thank you, sir.
Thank you. I want to start by appreciating the organizers of this program, particularly the CEO of this uncommon organization. I find it very thrilling to know that someone would think of this kind of organization in the first place. And I think the CEO needs plenty of commendation. I'm aware that her team has been working very hard to put this conference together, and I think they need to be greatly commended. I happen to have organized conferences over many years, and I know what it takes to put together one of this type, especially when the funds are not coming in as you expect. It also means that more people need to work harder to see that we're able to drive professional cohesion and resource deployment in order to advance the course of medicine, indeed the course of any career or cluster of careers that we may be interested in. But let's save time and move straight to the issues. I guess something is fading here. Okay, that's right. It's all right. All right, thank you. So that means I need more diversity and inclusion in my knowledge. Thank you. All right, so I'll be talking about a diverse force, promoting diversity and inclusion in surgical workforce. The only thing that brings me to surgery is the BS that you see there after the MB. So I hold a bachelor's degree in surgery. But beyond that, at postgraduate level, what I've essentially been doing is helping to develop standard operating procedures in order to strengthen ethical conduct, true commitment, accountability in the operating room. And that's been a big task. The second thing I do in theaters is to promote ethics, clinical ethics by the different professions. These are very demanding tasks. And I know that this topic actually addresses an important ethical issue, promoting diversity and inclusion. So this is the outline I shall be using. And by way of introduction, I want us to see the objectives quickly. We'll be looking at the concepts of diversity and inclusion. We'll look at barriers and benefits. We'll look at data that are available, the gaps, and then we'll look at the outline of the roles that stakeholders can play in promoting diversity and inclusion. Now, let's look at some key terms here. We're going to be using the word client. By that, we're referring to all persons seeking professional care from a member or team of the surgical workforce. And by patient, that means patients plus well persons seeking preventive and surgical care. So there are people who are well, there are people who are unwell, and they all constitute clients. Diversity refers to the representation of varied human characteristics in a group, such as a surgical workforce, as is our interest here. The characteristics of profession, gender, age, nationality, and so on and so forth define this diversity that we're talking about. Now, when we talk about inclusion, we're referring to how members of a group experience the group and its environment. And the word experience here is very important. It's not just a structural thing, unlike diversity that's somewhat structural in our ability to describe it, but inclusion has to do with the expressed experience of persons who are members of the group. It's how they are enabled to freely participate in and contribute to the group's activities, the objectives, achievements, leadership, culture, and so on and so forth. Now, no member of the group is treated as inferior or insignificant. The moment anybody experiences a feeling of insignificance or inferiority, that inclusion is not there. In other words, the very presence of diversity is not sufficient to assume inclusion. I wish we had more time on this, but let's just get that clearly. Now, promotion means advancing or furthering the well-being or status of group members in a manner that is supportive, where knowledge is improved, access to information, attitude, practice, skills, and so on and so forth. Now, when we talk about surgical workforce, it means human resources for surgical care. And that means nurses, doctors, anesthetists, anesthetic technicians, secretaries, administrators, and so on and so forth, in the bigger sense of that expression. Now, some variables help us to appreciate what we mean when we talk about diversity. These are just examples for us to appreciate. Profession, skill set, skill level, client match. Those are the ones that readily come to mind as experts. But let's remember that the public out there may be a bit more sensitive about gender, age, race, behavior, culture, and religion. Now, there is a demand end to diversity, that is the skill set for surgical care. And the supply end deals with students, trainees, skill set, or career choices. Now, the training school has a lot to do with ensuring that diversity occurs, and then the job applicants, and then performance at recruitment. All these are sensitive factors that are not easy to put together in management decision-making. Human resource experts, employers, and co have to cope with many of these factors. Having to compromise one or sacrifice one on the altar of another is an important challenge that every employer or human resource team would have to face. Now let's look at barriers and benefits in terms of diversity and inclusion. Barriers to diversity and inclusion in the surgical workforce. Most forms can be classified as institutional, cultural, or personal. They often manifest in different ways. Admission, for example, for training. And this is very important because it determines the eventual workforce, surgical workforce that you have in a health facility. Admission for training, how is diversity at that level? Recruitment, how is diversity at that level? What about deployment after recruitment? Appointment into leadership positions? Team dynamics, participation or contribution to team functions. What about promotion at work, in-service training, retrenchment? How do all of these play out in diversity and inclusion? Whenever we have factors like this playing out, they can potentially serve as barriers. If we don't apply diversity and inclusion in all of these areas, then a barrier is manifesting. Now, let's look at this at institutional level. Inadequate or absent supporting policies, lack of diversity and inclusion in management structure. When you have a health facility with a surgical workforce that does not reflect that diversity and inclusion, and there is insensitivity in promoting persons, or because of certain racial, tribal, or sentimental factors, some people suffer discrimination. Then we are not being diverse. Then there can be dearth of role models. You need role models to influence change in any society, in any system, including the surgical workforce. Then there can be unclear applicability of relevant legal provisions on human rights. Sometimes the laws and regulations are there, but how applicable are they in the true work setting so as to guarantee diversity and inclusion? That's a different matter. Insufficient advocacy is also a barrier because many people don't talk about it. Sometimes it is assumed away. But I think that this conference has taken a very bold step to expose these issues and open it up for discussion and consideration. Sometimes there is no training, and so people are not sensitive to it, and they just carry on that way. Cultural barriers are also there. And let me say this here. One of the things that promotes lack of diversity and inclusion is that people are brought up to just behave that way. You're told that, oh, being black means that, well, you're black, so you really shouldn't get promoted or go into leadership. And so if you're in a white society, you're European, and you see blacks that way because you've been brought up that way, something tells you you're doing what's normal. So it doesn't really strike you. Or you don't like a particular religion, and when you hear that religion, you feel uncomfortable. You don't even want persons in that religion around you. Or even from a certain tribe. And so, oh, these people, well, smile at them, but they are wicked. And then all sorts of ideas are there. Those things can be real cultural barriers that not only play out in the bigger society, but find expression even in the surgical workforce. Personal barriers also exist. You may never tell what somebody doesn't like about you. Somebody may not like your legs, for example. Somebody may just not like your face. Somebody may not like your complexion. And these are things that are inbuilt in the way humans perceive self as different from non-self. And the ability to make that distinction as what should not be a barrier is very important in our decision making. Then unconscious personal biases, yes, that's what I just talked about. Now, there are benefits when it comes to diversity and inclusion in the surgical workforce. Benefits to society, to surgical workforce, and most importantly, to the clients themselves. Now, the spillover in a triangulation, it's a win-win for all. Why am I saying this? It comes to the very first italicized sentence there. There is diversity and inclusion in the benefits of diversity and inclusion. And what do I mean? It means that when you practice diversity and inclusion, everybody benefits from it. The entire society does. When you don't do so, you are only narrowing the opportunity for society to grow, for society to develop, and for the surgical workforce to advance. So, as one group benefits, another does. The clients are benefiting, surgical workforce is, the society is, and we have a better place for the humankind. How do clients benefit? Let's improve communication. So, they're able to express themselves better. Healthcare workers are able to connect better. There's improved satisfaction and outcomes. Healthcare providers more easily gain the trust of their patients when they communicate freely. This promotes clinical judgment, client consent, and adherence to treatment. Then the surgical workforce itself benefits because there's improved clinical diagnosis from better communication, enhanced team performance, and better job satisfaction. Now, there's also reduced likelihood of litigation. No matter how you look at it, as society advances, there is a tendency for practice to be litigation-driven. A tendency for people to be afraid of what harm can happen to them, that is, workers, health workers. That means that sometimes decisions are not based on beneficence, but the fear of maleficence. And that should not be what surgical workforce should be doing. Then improve referral practices to suit patients' needs and preferences. So when you appreciate that this patient has so and so background, you may want to vary the team that will manage that case. Improve reward from improved service utilization, improved research and innovation. So everything really gets better for the surgical workforce. Now, to surgical workforce employers, this is very important because when clients recognize that an institution is practicing diversity and inclusion, then there is improved reputation for the organization and better employee retention. We've been talking about retention, where people feel that they belong, when they experience being a part of a system. Their clients also benefit from that arrangement, and the employer benefits all the same. The society has improved trust in the health system when that happens. Pace setting for society and global community is also improved. And of course, eventually we have an egalitarian society. Now, let's look at some data, but we must say, first of all, that we know we need data, but data are lacking, measuring diversity and inclusion. All right? We need data to provide evidence that diversity and inclusion are lacking and continuously evaluate progress in response to whatever interventions we introduce. We cannot talk about improvement unless we have data to show that. Now, the situation is that published data on diversity and inclusion in surgical workforce are scanty and absent globally, with exceptions like the US. Even in the US, it's not so much. It's only in recent years that we have some data. Perhaps the best data for our local use are the data and observation at our individual workforces. So let's look at this from the US in 2022. Males, 83.8%. Females, 16.2%. This is the faculty in the US, where they had medical faculty with nurses and surgeons and so on and so forth. Then you have Black Americans. They have African American and blacks rather, 5%. Asians, 16%. So you can see the distribution. I'm a statistician, and naturally the first thing that crosses my mind in comparing data like this is to ask myself, what is the distribution of these races in the society itself, in the country or in the state that we are dealing with? The moment you are able to appreciate the diversity in that society, it's easier to appreciate the statistics. If you are in the US, you can appreciate that this does not describe how the society is distributed. It means that we don't have enough of diversity and inclusion. And the problem may not necessarily be with the health facility. It may even have started from the very educational institutions themselves. Now, in the UK, in 2020, 55% of the intake were female, but less than 30% continued to hire surgical training. In 2021, in the 2021 publication, only 7% of orthopedic consultants are females. Now, this is just to draw our attention to the way diversity and inclusion plays out. This is not to indict any institution or individual. In fact, for you to understand this better, you may well look at the distribution of applicants for jobs. If females don't apply, you can't probably have enough females to fill gaps. If males over apply, you don't want to discriminate against males because they applied. And these are difficult times for human resource experts. But it draws attention to the fact that where there are gaps, we can seek to fill them by tailoring our preferences in career choices. And at the point of training, admission of students, and so on and so forth, we can begin to fill the gaps and ensure that some of these factors don't play out. Next, certified registered nurse anesthetists in the US, published this year. Females, 56.9 to 59.6. Males, 40.4 to 43.1. Let's look at ethnicity. Can you see how it's represented? All of this draw attention to the fact that we need to monitor this data and understand where we ought to be. Now, how do we really promote diversity and inclusion? The government, all arms of government, relevant agencies have important roles to play. So they should enforce the collection, analysis, monitoring, and evaluation of data on diversity and inclusion using appropriate indicators. This is important as regulators because they need to take decisions that are data-driven. They also need to strengthen and enforce existing laws and implement policies against stigma, discrimination, and repudiation, and those that support diversity and inclusion. Now, enact new policies and laws to fill existing gaps. Wherever they are identified, they should be dealt with. Yes, it's one thing to have a national commission that tends to work against diversity and inclusion in the general society. It's a different matter altogether to publish data on them and encourage society to respond to how this data play out. Underrepresented populations such as females, persons in poor conditions, in poor communities, communities where people don't encourage education. How do we improve their representativeness? It has to be very intentional. It means that if people are not going to school in your community, you should encourage them to go to school. It's not enough to say that there's discrimination against my people, but they should be encouraged to take up training, take up skills, so that they can compete favorably, all right, whenever there are such opportunities. Then I also believe in speaking out. If we speak out against stigma, discrimination, and exclusion, then we are doing the right thing. And that's why I like Sorosoke, speak up without fear of violence. And I think that's what TORG is doing. I thought you would give a clap to that. Excellent thing. If you don't talk about it, nobody does anything. So TORG, thank you for Soroin Soke. All right. Members of underrepresented populations should also demand for their rights, refuse and denounce discriminative tendencies, publicly expose overt and intentional acts against them, and applaud uncommon acts that promote diversity and inclusion, including what TORG is doing. Where you notice that you are overrepresented as a group, you can show concern for underrepresented groups. It doesn't have to be that, oh, it favors me, so I keep quiet. When it doesn't favor you, speak. When it favors other people and over-favors you, also speak out. That shows that you are being fair. Now, advocate for diversity, equity, and inclusion, then publicly applaud acts that promote diversity, equity, and inclusion. Employers should create non-toxic hospital environments that will make people feel at home. They should also institute and implement adequate policies and guidelines, reflect diversity and inclusion in management structure and in leadership structure. Employers should intentionally diversify recruitment, deployment, promotion, retention practices in surgery, or use blind recruitment processes where they cannot be indicted. They should also project role models and advocate for diversity and inclusion in practice. Then train hospital staff on diversity and inclusion. Civil society organizations have a lot to do. They have to look at the legal provisions and existing policies, advocate for health sector, D&I, educate wider society, D&I, work with underrepresented and overrepresented groups to review what we have on ground and make recommendations and seek to have them implemented. Promote partnership between hospitals and organizations that support underrepresented groups. So if you want more females, for example, why don't you talk with NGOs that promote female employment? If you want more people from an underrepresented society, why don't you talk with community leaders, community-based organizations from such? What about the demand for accountability and responsibility? That's a great thing that our political leaders must be held to. The surgical workforce should act in-house to project role models for diversity and inclusion in surgical practice and leadership. They should advocate for training, including mentorship and employment in surgical practice. All right? They should also advocate for policy and legislative action, conduct audits, service evaluations, and research to identify gaps and opportunities for improvement. They should also emulate our very amiable Adebusola Omokhoa and support TORG. Training institutions can play an important role here for surgical workforce. That is, they should intentionally correct admission gaps and create multiple training and career pathways, project role models, advocate for employment in surgical workforce for underrepresented groups, and conduct training, all right, for staff in this subject area. Now, matters arising, balancing the issues. It is not as easy as said. Like I said earlier on, human resource experts will have to examine carefully what it costs, all right, to, for example, sacrifice a skilled personnel that you need in order to meet up with diversity and inclusion. It's not very easy, but some of those decisions may have to be taken in order to ensure that the services that are offered by the surgical workforce are acceptable to clients and society at large. This careful decision-making will have to be done in a manner that reminds us of the Pareto principle, which I just captured at that corner. The principle of optimality or efficiency, which states that no further improvement to the well-being of a system can be achieved through continuous preferential reallocation of resources that makes one section better off without making another worse off. So a careful decision-making process will have to strengthen choices in a particular direction to ensure that we are ethical, we are meeting up with diversity and inclusion without doing harm to the technical skills that we need as much as possible. Now, stakeholder collaboration is important. I just put this together so we can appreciate the role players in different ways. Concluding, I would like to say that we have explored benefits and barriers. We have looked at methods of promoting diversity and inclusion. We must identify where we belong as stakeholders, play our various roles, strike the necessary balance, go beyond rhetoric and concept admiration to actual action, that is by mobilizing our various trained and practice institutions and other stakeholders to promote diversity and inclusion. And above all, emulate Dr. Adebusola Omokhoa and support TORG. These are my references, and I thank you all very much for listening.
All right. Thank you. Thank you once again. Thank you.
Thank you, sir.
I'm not sure if I will value any presentation as much as I value this. I'll let you know why. Yes. As a person, from experience, I've also had the opportunity to work in both the public service, healthcare system, as well as the private setting. I do know that the fact that we're here in Lagos, Nigeria, and I've practiced to a large extent here, it gives me the opportunity to talk about this before we go into observations, questions, and answers. Inclusion. All inclusion is one thing that I know will help the operating room practitioners a lot if only we decide today to embrace it, just like Prof is advocating for. Several factors. He's mentioned so many, and I'm sure we are abreast with them. If you leave me to create a schedule of benefit in the operating room setting, for example, it will be me first before every other person. If care is not taken, because of that opportunity that I have, I take 10 and I want to share 1 for all of you. So you cannot talk about, therefore, all-inclusiveness when we don't even look after ourselves as far as welfare and pecuniary matters are concerned. So, as moderator, I just felt I should seize this opportunity, being with the microphone, to say this, that we really need to reconsider the way we do things with reference to what Prof has said, because it's a big factor to consider as far as 2 things are concerned: benefit to clients in terms of outcome, and because everybody belongs to this same society, if we are happy for it, the society is also happy and better for it. So, once again, let's give Prof a round of applause. Thank you very much. I'm sure we may be getting towards the hypoglycemic part now. So, following question and answers, we'll take a break briefly and visit that joint there. Before we get there, I think we would want to take, for now, 1 question this way, 1 question here. I wish we had time. A topic like this, I know there will be several hands up, but let's not waste time. Uncle, please, quick, let's.
Thank you so much, Prof, for the presentation. During the presentation, you mentioned that the underrepresented group should speak up. And this afternoon, I want to take this opportunity to speak up on behalf of the male nurses in Nigeria.
Male nurses?
Yes, sir.
Yes.
Though I don't have the accurate statistic, but I can say that the male nurses are less than 10% of nurses in Nigeria. And this is also reflects in the operating room. For instance, just last week here, we had a patient for surgery. The patient had a penile fracture. And
the patient had what?
Penile fracture.
Okay.
So the patient specifically requested that all the staffs or operating room personnel attending to him should be male. And in a situation where the majority of the perioperative nurses are female, you see that there will be conflict between the patient's demands and the care that is being given. So I want to ask this question: what is being done in Nigeria today and Africa as a whole to increase the ratio of men to women ratio in nursing profession and other professions that are also affected? So that is my question. Thank you so much.
All right, thank you. I wish we had more time. I would have asked people to respond from the audience, but for want of time, thank you. For want of time, I'll just put it this way. It's better for us to take what you have said as a recommendation rather than a question. So it means that decision makers here should go home with the mind that we need to be more sensitive to the individual needs of our individual patients. When there is a patient of a particular type, that's not when to insist on a roster that's been drawn up. You may want to alter the roster a bit for the sake of that patient, and then do a balancing adjustment, readjustment, so that we can always work in favor of it's something we need to really think about and start working on. It's not so difficult. It's not rocket science. Once a patient has expressed a preference, let us do the best we can to respect that preference, even if it's just for the sake of that patient. Then the next patient, then the next patient. Before you know it, word will go around that, that hospital, they are very good. They respect the wishes and preferences of their patients. Is it easy administratively? No. Is it likely to inconvenience surgical workforce? Yes. But does that give us a better image to the general society? Yes, it does. And I think that's the bigger thing. So thank you very much for that recommendation. But penile fracture is a terrible thing to have, by the way.
Thank you very much. I like to follow the precept here. We've gone this way, so let's go this way. And a man spoke here, so a woman should talk. Please come. Thank you.
Is that diversity and inclusion too?
I'll leave it to you, sir.
In everything we do, we should do that. Thank you. I just want to acknowledge your wonderful and highly educative presentation, sir.
Thank you.
You said in your presentation, no member of the group should be treated as inferior or insignificant in a subject that is subjected to overt or covert aggression. Now, in your barriers, you listed cultural and personal barriers.
And institutional barriers too.
No, I just want to say those two.
All right.
Cultural and personal barriers. How can we, help to stop its mitigation against inclusion? How do we, cultural barriers, personal barriers, how do we, try as much as possible to, how do I put it? Because you said it influences inclusion. How do we help people with those kind of cultural or personal barriers, help them out of it so that they will feel included? Because you said everybody must be included. Do you get my question?
Very well.
Okay.
Thank you. So, my recommendations in a general sense have addressed that. However, when you have a specific situation where the workforce is already experiencing such from one or two members, what is necessary is for the leaders of that team or the workforce to take aside such individuals and counsel them. Counseling is very important here. But if you're listening to me clearly, it means that there is an assumption that the leaders themselves don't have the problem, which means that the primary people we should be dealing with are the leaders. Once leaders do not discriminate, once they don't have such biases and tendency to want to narrow down to bigotry and such things, then it's easier for them to use their examples to influence members of the workforce. It all starts from our personal tendencies and orientations. I told my children many years back that, look, feel free to marry who you want to marry, as long as you have the clear principles of integrity and the fear of God by which you have been brought up. My first daughter came up with a husband from the north. I'm from the south, in South Nigeria. And I had no problem with that at all. My second daughter, southeast, from Mbano. I said, oh, Mbano, beautiful. That's yes from me. So I don't have a problem with that. And they're fantastic people. But when people are brought up to believe, my father told me many years back, before I got married, that, look, don't marry from 1, 2, 3 ethnic groups. consciously, I started looking for ladies from those groups from which he said I should not marry. I just have to be careful not to overdo it. I didn't marry from my state anyway. But the important thing is this, please, let's free up our minds. Humanity is one. What's important is that we assign value to people based on what they can deliver and enable those who are vulnerable, who suffer some gaps in knowledge and skills, to gain those knowledge and skills and make society better rather than discriminating. And sometimes you see that even better hands are discriminated against. And it has happened in a surgical workforce that I am aware of. In one case, the young man had to leave the country and went to another country for better opportunities. He was discriminated against in spite of his surgical skills, obvious leadership skills, and so on and so forth, because of his ethnicity. So such things are things we must discourage, and we must lead by examples. Now, with all of us having shared what we have discussed today, if we all go back practicing the right things, you can imagine what will happen. Looking at many faces here, you are leaders. You may not hold titles as leaders, but you are in the older segment of your respective professions. And that means that we have the opportunity to influence what happens in our small teams and among the people whom we lead. And hopefully, that will cascade down the entire system and society. Thank you very much.
Thank you very much. A round of applause for Prof as he goes to take his seat. All right. I think this presentation was what the FCT minister tried to bring to bear when he said, can I remember, for those of us that are Nigerians and are familiar with the language, he said, which means, I'm not Igbo all the same. But what I deduce from it is there will be peace. If you give, you consider A, give to A, then consider B, give to B. If possible, the same measure with which you used to give to A, use that same measure possibly and give to B. There will be peace, there will be effectiveness, efficiency, and in the operating room setting, the patient will be happy. All right.